atypical neuralgia, heart palpitations, orofacial pain, tinnitus. I'm going to say connective tissue disorder, hypermobility, Ehlers-Danlos syndrome on the spectrum somewhere. You're a slender-necked female. We're seeing some hypermobility up there. And I guess one of the simplest sentence that I heard to describe this is, we have an uncommon presentation to a common problem. And the reason you have such an uncommon presentation is because of this, the way you're plumbed. We found a basilar vertebral Dolichoectasia. Basilar vertebral Dolichoectasia. So when we look down through the top here, normally you'd say, come real close for this. You want to really get right here on this one. So basically, when you look down through the spinal column, the spinal canal, you have an artery that is in the middle, and it almost in the middle, and is functioning like a space-occupying lesion. That is, it's occupying space, and people are born this way, and yeah, their symptoms can be a little different when they get their heart rate up or whatever, but they're typically dormant and not causing enough symptoms for somebody to pursue it and to be certain that this is what's causing it. But then you take put this in a slender-necked female who gets T-boned from the side and carries a heavy backpack and is on the connective tissue disorder spectrum, in my opinion. Then you have this hypermobility, and we've documented that when you turn your head to the left and turn your head to the right, it moves quite a bit. So we've shown this Doli moving left and right, and it's right up against a lot of neurological structures in there. Now, they've worked you up for trigeminal neuralgia, and when they've done that, they would have looked for the internal carotid if it's making contact with the trigeminal nerve. Now, the good news is we've had a lot of great results with trigeminal neuralgia. Not just me, but a lot of people that adjust the atlas at a high level of skill. We've fixed hundreds of trigeminal neuralgia. And how have we done that? By fixing this atlas misalignment and normalizing some of that hypermobility in there. Now, one thing that has happened is that they've injected steroids in here. Again, a lot of people are being diligent trying to find the problem, and when they injected steroids in this area, a lot of your symptoms got better for a little while. So what you don't see here is the nerves that run through there. There's 10 nerves that run through there. I could give a list of them, but it's going to be time consuming. Either way, we've got an elongated styloid, a calcification of stylohyoid ligament. When you bring your head down in flexion, it's going to pinch that. The one on the other side is really long, so long that it's going to interfere or pinch the internal carotid with enough flexion. Okay, so this was diagnosed in and of itself. Now, your jaw is not exactly great, so a lot of guys have been trying to reshape your jaw and really get the TMJ right, and they're not wrong because there's an issue there. When you were T-boned at 16 years old, I think the forces that went through there kind of set you up with some hypermobility that would have injured the jaw a little bit. I mean, we're all kind of asymmetrical, and because of our asymmetries, we take loads differently. So here we look at you from behind, and you can see how the cervical spine goes off to one side. Now, in a moment, I'll show you where the first ribs are subluxated, the ligaments have been compromised, they're dropped down. Here you can see the shoulders down on the one side. So you think levator scapula, you think the scalenes. Well, the scalenes, because they're not going to be able to modulate correctly. And actually, I should probably go right into the screenshots. It tells the story better. Yeah. Okay, here we go. All right, again, looking down at the Dolichoectasia. There's another view of it. Here you can't see that vertebral arteries too well because there is venous congestion and it's dilated up in there. Yeah, we'll cross that other. I was going to say that there could be, well, there's a lot of things it could be, but we're just going with the most likely thing, and the most likely thing is the hypermobility that's taking this doli and making it active. So the neat thing about you is that you'll sleep, you'll wake up, and you'll be asymptomatic, and then as the day goes on, you present like a trigeminal neuralgia, but then I like the neurologist did call it atypical neuralgia because it's a little bit of a different pattern and kind of hard to pin down. Okay, here you can see the styloid getting the internal carotid there. We're drawing a line through the center of the foramen magnum. We did adjust you from the right, and that worked out pretty good. So one of the things that we found with this styloid, it looks like when you bring your head down, it's going to push the atlas back on this side and forward on this side. Now your symptoms are primarily behind your right jaw, somewhere in there. Actually, it maps out with a trigeminal neuralgia, but it's not just that. So this hypermobility in here is wreaking havoc in through there. So what do? We want you to get some prolotherapy or any of the therapies that tighten up ligaments. Of course, we adjusted the atlas today or yesterday, and you're holding the adjustment today. Okay, so here we are. We see these first ribs have been dislodged. They're not even making it. They're not even attached anymore, and they're down significantly. The right one more than the left. I've seen this on other people to where one is in the neutral position and the other one's down, and it pulls the whole neck over. You've got them down on both sides, and I think it's fostering that kyphosis in the cervical spine, the anterior head carry that you have, and the one on the right is the worst. So the scalenes aren't going to modulate correctly. It's going to kind of pull you over, and we've seen that with people in the past. Not bad enough for a surgery. I spoke with different surgeons on this. There's not a surgical intervention for it yet, but the prolotherapies or anybody who's going to tighten up these ligaments and get these to where they don't wobble so much and the muscles can modulate better, that seems to be where we are these days. This is left head rotation. We documented how much it moves to the right. Right head rotation, we documented how much it moves to the left, and then it also rotates. And that's what we went after yesterday. There's your left and right rotation. Here's another view of that dolichoectasia, how it's pushing on the brainstem and the spinal cord as it runs right in through there. Here's another view of it. It's supposed to be symmetrical. It kind of looks like somebody's taking a bite out of an apple. So again, people are born with these, and they're typically asymptomatic until you get a bad whiplash or something. And this is just showing the normal anatomy where it runs right along the side there and it's not really interfering with anything. There's a good view of it. So the fact that these can be dormant and asymptomatic in people that are born with it, I mean, that's great. But again, when you get a hypermobile cervical cranial junction, they start to give you funny symptoms that they'll call it atypical neuralgia. And we did a search showing how many times, showing vertebral, basal vertebral dolichoectasial, vertebral basal dolichoectasias causing the trigeminal neuralgia to play out. We did take an inventory showing that doesn't seem to be a continuity between your right sinus, transverse sinus, and your left. They're independent. So what does that mean? It just means that the left side of your brain drains on a different system than the right side of your brain. I don't know that. Okay, this is the thing I was going to mention before. So we've seen this be an indicator that somebody had a venous fistula, arterial venous fistula, an AV fistula. It doesn't mean you have it. I've seen it to where that's what it looked like before. So again, you're probably going to get a study to have that ruled out. Make sure you don't have an adult AV fistula there. Oh yeah, we did show how far this first rib dropped. So 6.72 millimeters that's a significant drop in there. And one of the things, the way to talk to people about this doctors in the future is that you show them these things and say, hey, what do you think that would cause? Well, we know that the stellate ganglion sits in front of these, and there's centers throughout the country where they do stellate ganglion blocks for PTSD and anxiety. So it's easy to think that your stellate ganglion is irritated and driving you into a sympathetic state. These clinics that just inject into the stellate ganglion to get that whole sympathetic stimulus to shut down, and they started doing that after World War II, finding out that they could treat PTSD that way. Yeah. Oh, another view showing how far it's disconnected from there. All right, this is the left head rotation, showing how the Doli shifts from side to side, or shifts, actually it looks like it shifts out of the way and pulls down a little bit. We did show some of the muscles that would be, then that shoulder being down, pulling that neck over to one side. Just some of the muscles that would be playing out there. Thought we'd itemize those. Levator scapula, of course, being the chief one that you think. Okay, and that we have a styloid that, now this is normal anatomy, which nobody has. You have a styloid that is showing, that comes across here. This is the carotid sheath that we're highlighting here. And it's not too far of a stretch to think that a hypermobile jaw, hypermobile cervical cranial junction, calcified styloid in an effort to stabilize this area with the movements. And I've seen you move. You got a lot of movement up in here. So it's not too far-fetched to think that that's going to irritate some of these nerves. And then the fact that you were injected with a corticosteroid in there, and it got your symptoms to really improve for a while, for a couple days, that is diagnostic in and of itself. Okay, so this is before and after the adjustment. We see how crooked you were. We adjusted from the right. We adjusted pretty much from right to left. You didn't hold that adjustment more than 5 minutes. And then we added some anteriority from the right, and you seem to hold that adjustment from yesterday. So this is an x-ray we took yesterday. This is an x-ray we took today. This heavy bowling ball is not leaning over as much as it was. And the biggest number showing this here, it went from 3.93 degrees to 1.29 degrees. So it basically went from 4 degrees to 1 degree. And that loading is going to translate into things. I'm actually going to be sore in different locations, but that's going to be better. Any questions, anything you want me to talk about?
You showed the vertebral artery when I was turned to the left and how it kind of got out of the way.
We never did screenshot the one on the right, did we? We talked about that, and yes. So, right, that. Okay, let's do that. Let's pull that up.
I know I don't like to turn my neck to the right, so just curious if anything
right.
there.
Yeah, and I definitely want you to wear a collar, and I want you to cease and desist all that head gesturing and moving. Again, the current working diagnosis is that there's an irritation that's occurring there. I mean, it's great that you can wake up in the morning and feel asymptomatic pretty much, but then it comes back throughout the day. So there you go. There you can see how the Dolichoectasia moves to the side. This is right head rotation. So here I can't even make it look like it's in the center anymore. So it seems like with left and right head rotation, it moves significantly. We don't want you to move too much. You're a slender-necked female that got T-boned and from the side, and there's a looseness in here. We don't like the fact that it moves too much. The fact that you move too much in here with this Doli, you're gonna be confounding to your doctors. And yes, it looks like it moves out of the way with right head rotation, and it looked like it moved out of the way with left head rotation. But either way, we have a structure that's moving back and forth, back and forth, back and forth with movement. We have an atypical neuralgia. I think it's irritating neurological structures there in an uncommon way. And just stop moving your neck, get it tightened up, and this thing is going to move less, and the neurological structures are going to be happier with it you know, if I put a knife in you and then pull the knife out and then put it back in again, you're almost better off with a knife staying there and healing with it in there than to take it out and put it back in, take it out and put it back in. These hypermobilities, they irritate a lot of structures. Okay, is that good?
Thank
All right.
you so much.